But now it's my pleasure to introduce Michele O'Connell. I don't know Michele nearly as well as I know Anton, but she's okay in my book because she's a rugby union fan, and we had a good chat outside about how well the Irish rugby team is doing at the moment. But when she's not watching rugby, she's a paediatric endocrinologist at the Royal Children's Hospital, and some of her research work, as you see in the blurb, is focused on the development of the brain in patients with diabetes. So Michele's going to talk about pathways to a common goal. So please join me in welcoming Michele.
Thank you, David, and I'd like to thank the organising committee and everyone for inviting me and for staying till the last talk to listen. So yeah, as David mentioned, sort of my brief was around talking in terms of pathways to a common goal, and that's going to be the main. I do have a research interest in the impact of diabetes on the brain, which I haven't dwelled on particularly in the talk, but we'll be very happy to answer questions about should anyone be interested. So in terms of the overview for the talk is just there. So we're chatting about challenges for the children and adolescents, and I think Lisa has very eloquently outlined these this morning, and in fairness overall, I think we probably have a good understanding. These two graphs show, or CGM traces show, what happens with diabetes. And the one on the left is someone who does not have diabetes with a very flat, stable glucose pattern throughout the day. Whereas on the right, you can see these peaks and troughs that characterize diabetes. So because of the insulin deficiency, it is absolutely characterized by disordered glucose homeostasis. Glucose is the primary fuel for the brain, and that's why there are impacts on the brain that are both acute and chronic over time. In terms of acute day-to-day things, again, these have been gone through, but the problems that people face day-to-day are not just in relation to the rigors that are required in terms of their daily management, but also managing high blood sugars, low blood sugars, rapidly fluctuating blood sugars, and the psychosocial impact of feeling different to one's peers all of the time. On a chronic basis, then there are the long-term complications, and they tend to be, the sword of Damocles sort of hanging over people. And while children and adolescents don't focus on them, they're very much the fear of parents and of managing teams, and they tend to be the thing that trying to minimize those tends to be the thing that drives overall the greater goal. Yet all of the time we need to be focused on how we best manage these acute complications as well. As Anton has said, there's an increased risk of poorer mental health and chronic impacts on brain function. So the optimal care aims to minimize all of those issues, and that is clearly easier said than done in terms of how day-to-day things work and how over time priorities can change. This is just to touch on this. So there are a number of cognitive skills for learning, and particularly in young children, the younger you are when you're diagnosed with diabetes and your cumulative exposure over time, we know that diabetes has a significant impact both acutely and in terms of during acute hypoglycemia and acute hyperglycemia on brain function. And over time, there are a decremental impact in all of these areas of functioning that weren't there at diagnosis. So we know from control studies, longitudinal control studies, that children, when they're diagnosed with diabetes, don't differ from their peers, but over time, with diabetes, decrements evolve. As I said, the macrovascular complications tend to be the microvascular complications tend to be the big focus, and these are the graphs that are standard in any diabetes talk. I'm surprised I'm the first one up, but in terms of this is the DCCT, we knew about these, or me personally, but physicians knew about these for a long time. People with diabetes knew about this for a long time, but until the mid-1990s, it was not clear that it was hyperglycemia and chronic exposure to hyperglycemia that was the sort of causative pathophysiological process. And that almost seems difficult to believe now in terms of, it's just so ingrained in our management. But prior to that, and it may well be why the path for young people who get diabetes now, because we know about this versus, elderly relatives who may have had diabetes. For a lot of their time when they had diabetes when they were young, they wouldn't have known what was going on or what they could do to change things. But we know from the DCCT there were significant large reductions in both retinopathy and kidney disease. And this is just to show you in terms of HbA1c. So the conventional trial, you can see that across the entire study there was a difference in HbA1c, and that was maintained throughout the 9 to 10 years of the study. And overall, there's a very close association between HbA1c and the risk of complications. And this basically has changed how diabetes care has evolved. But 30 years on from the DCCT, diabetes is still the leading cause of preventable blindness in Australia, and kidney failure is 3 times more common in people with diabetes than it is in the background population. And so clearly, while we've made some inroads, we're not where we need to be. So the goals of management, there are numerous international clinical guidelines, but the primary treatment goal is based around HbA1c, and the target that has been agreed generally internationally and is now relatively standard is less than 7.5 in pediatric and pediatric age group up to 18. Although interestingly, the NICE from the UK last year, when they updated their guidelines, have set to aim for under 6.5%. The other qualifier on that is as near to normal as you can get it without significant or recurrent frequent severe hypoglycemia. Obviously, there are lots of additional goals, and so it's not all about HbA1c, but it tends to be this focus, as Phil was talking about in the consultation, it's what people want to know what that number is, and beyond that, then things go either direction or in many directions. So where are we at? So you can see across the timeline of diabetes right back from the 1922s when insulin was diagnosed right up to sort of when the DCCT was published. It was really only in the 10 years prior to the DCCT that more things like transformative things started to happen. Again, blood sugar testing was only available from sort of the mid-80s, and since the new millennium there has been an explosion in terms of increasing additive sort of therapies and cares and technologies and things that are designed, I guess, to try and help improve overall diabetes management. In this post-DCCT era, how are we doing? So in the early years, certainly in the initial decade post-DCCT, you can see from big cohorts in both the US and in Perth, in Western Australia, significant changes across clinical bases and in large enough populations, looking at improvements in HbA1c. This, like I was saying, so the things that have come about, so we have increasingly sophisticated technologies such as pumps, smart pumps that can do calculations, continuous glucose monitors, newer analog insulins that have come in and are almost universally used, and then combined blood glucose and ketone monitors. These things weren't around pre-DCCT, and we take a lot of them for granted now. And then additional things that patients can use, like care-related apps. Despite all of that, unfortunately, from an HbA1c point of view, we are somewhat stuck. These studies look at multinational data, so data across many centres, in collaborative groups where they've looked at centres in a number of different countries. And the mean HbA1c, these are in paediatric and adolescent cohorts, tends to be 8 or above. And yet we're aiming for this target of under 7.5%. Similarly, within different countries, so where they've looked across national databases, you can see that with the exception of the Swedes and also Slovenia, again, the mean HbA1c in many countries, looking across their benchmarking of different, again, often large academic sites, tends to be in the low to mid 8%. In Australia, the Australasian Diabetes Database Network was set up and established, and data from that shows that the mean HbA1c is 8.2% in the last September last year. So we are a bit stuck. We're not, that downward trend that was seen post-DCCT, and I guess, there's an element of the higher it is, the easier to a degree it is to get incremental change, but we do seem to be in a position now where for a number of years the mean HbA1c isn't changing. So what have we got? What are our current insulin regimens? So the options, essentially, there's broadly speaking 3 broad options, and I think most people here, sorry, I thought there was about a mix of medical and non-medical in the audience, but most people here will know the various options. So twice daily insulin injections essentially give an injection in the morning that covers through the day with a mixture of short and intermediate long-acting insulins. In that sort of a regimen, you'd probably have 2/3 of your insulin in the morning and 1/3 at night, just based on the distribution of food during the day. Multiple daily injections of insulin have short-acting insulin before main meals and sometimes before snacks in addition. And insulin pump therapy is different again, so essentially all short-acting insulin with a background maybe of 35 or 40% of continuously delivered basal, and then patient-administered boluses. There's no question that insulin pump therapy is the best mimic, or the best physiological mimic that we have of what a pancreas would otherwise do. So no pancreas in the morning wakes up and gives 2/3 of the daily insulin for the day. And so small amounts more frequently is what your pancreas would do. However, as lots of people have mentioned, it requires, it's only as good as the information it gets. And again, I think if we were to do it, how many of us have put food in our mouths without actually realizing that we've put it in? You know, people eat without really realizing, pick up a biscuit, pick up a piece of fruit, whatever, and then go, oh my God, I've eaten that. And so it's not an intentional insulin omission, but if people aren't giving boluses, you've got no background insulin, and so it's only as good as the information that it gets. In terms of which regimen to use, so which one of these is best, and the ISPAD, or the International Society of Pediatric and Adolescent Diabetes, in their most recent version of their clinical practice guidelines, have suggested that as close to physiological insulin replacement as possible and optimal glycemic control must be the aim. So they've defined optimal glycemic control as under 7.5%. However, the choice of insulin regimen should depend on many factors that are there, and in particular, what's going to fit in with the family. What's going to fit in for that young person? A pump is not best for everybody. Multiple daily injections don't work for some people. Things around school can be difficult. So there's no one regimen that's going to fit for everyone. Interestingly, they state that overall there has been a paradigm shift towards multiple daily injections and CSII, which is insulin pump therapy. And nowadays they say that they're becoming the gold standard of care in pediatric diabetology. And the NICE guidelines and the American Diabetes Association guidelines say the same thing. However, they also say that that unequivocal evidence for benefit of multiple daily injections, the analog insulins that are almost universally adopted, and insulin pump therapy treatment in children is in fact lacking. So while these things are coming in and are becoming more commonplace, they have not been shown to be definitively better. This is just the NICE guidelines, so they essentially say the same thing. They say to offer a physiological basis, so MDI or insulin pumps from diagnosis, but they also go on to say that if people aren't managing with that, then a step back, maybe to simplify the regimen for 2 injections, is also appropriate. And in all guidelines, taking the family's and personal circumstances into account is really important. So the Australian-based guidelines, or Australasian-based guidelines, issued through the NHMRC with APEG and ADS input, we were slightly more guarded, and probably appropriately, I think. So they say that insulin pump therapy should be considered for use in individuals where the magnitude of benefit is clinically significant, is likely to be clinically significant. But the evidence is grade C. And the evidence that was in 2011, and although their uptake has increased, the evidence for the benefit hasn't changed. This is the most recent meta-analysis, which was in 2012, and there was no difference on moderate strength evidence. There's no difference in randomized controlled trials between benefits of insulin pump therapy and CSII. The previous one in 2009 had shown a weighted difference in HbA1c of about 0.3% in favor of insulin pump therapy, and generally speaking, a difference of about 0.5% in HbA1c is thought to be clinically significant. Obviously, there's a caveat that there are different, flexibility of lifestyle, quality of lifestyle, those kind of things do impact. I'm not suggesting that they don't, but at the same time, I think we need to keep this in mind when we're sort of weighing up the evidence and having discussions with families. Also for hypoglycemia, severe hypoglycemia and mild or nocturnal hypoglycemia, there was no difference in the meta-analysis. The other factors that people have talked about are the costs. So these, new insulin analogs that are, widely used, very widely used, they're really expensive and they're increasing in expense. So in the US, up by 500 to 600% over the last, not even 20 years, 15 years. And annual diabetes costs in the US have increased, almost half-fold in the 5 years between 2007 and 2012. So diabetes is costing increasingly more. That's obviously not all type 1 diabetes, there's type 2 diabetes in that, but nonetheless, there's a significant cost to the public purse. And I think we just need to keep that in mind. In terms of in terms of universal care, it's not that we need to be careful that we're using something that has proven benefits and is going to be a benefit to the person that's using it. In terms of pumping in Australia, again, so they're not universally publicly funded. The majority probably will know that. But even when they are, there are significant costs, as Lisa was saying, to the family purse in terms of consumables are subsidized but not completely funded, and there is If you don't have private health insurance, there's a means testing funding scheme through the federal government. Not everybody qualifies for that in terms of their income, so they aren't universally available, at the best of times in Australia. Technological failures, like Lisa was saying, the issues that they've had with the line. So it's an added way, it's a different way of giving insulin, but it does rely on a pump and a motor, and it's a device that your backup is always going to be an injection of insulin. So, and those issues are not infrequent, and often can cause quite a lot of distress, or can cause people to become unwell because of DKA if they have a significant line failure or pump failure. So what about CGM? So again, the evidence for CGM is a little different. So there is some good evidence for improvement in HbA1c and time spent hyperglycemic when using CGM with a pump versus pumping on its own. However, the evidence is not as strong in randomized controlled trials for looking at hypoglycemia, which is interesting based on the fact that the recent release of CGM has been very much driven towards prevention of hypoglycemia and use of alarms and nocturnal, for use in hypo unawareness and for people who previously had severe hypos. There's a number of studies that have showed marginal, or no difference between groups, and in particular, I think in children and adolescents, so not young children, so young children where parents were driving it. There have been some studies that have shown no difference and some studies that have shown small differences, but the big thing seems to be the duration of time that you can wear it. And again, even chatting with young people in the clinic, since the scheme has been announced, having another thing attached to you, another thing that you have to wear, another thing that you have to interpret, not everyone wants that. So it's another degree of intensity, a degree of difficulty that I think the information that you get, if there's a perceived benefit from that, then great. But if it's just another thing to wear, then there are downsides to that, and that's very understandable. So again, I don't think it'll be for everybody, but I do think that there will be scope for it to help and be a support or an aid for many young people. Meanwhile, I guess in the face of sort of the scientific or evidence base in terms of randomized or high quality data is marginal, shall we say, and yet there consumers and young people and their families, there's a lot of online exposure to how good technologies are, that they are better, and some families feel pressure from that, and it's trying to weigh up the pros and cons and weigh up what it is people think would be of benefit versus the extra added potential stress for people or difficulty for the young person. It's very much a transition from parent-driven care to young person-driven care when people go onto a pump having been on injections, because the onus on delivering the insulin, pushing the buttons, very much goes to the young person, particularly in the hours when they're outside of the home. And so we've got this sort of, again, a perfect storm situation where we have an increase in expensive therapy options that are non-transformative in terms of they haven't shown, those decreases from 11% down to 8%. We're not getting that magnitude of benefit. There's an increase in patient demand, and then there's some sort of, social media sometimes pressures for families, or they feel like they should be on something because it's deemed to be better. And I think that we need to be careful, because we are sometimes cautious. We are very supportive of families if they want to use technology and they perceive that the benefits will be for them and their lifestyle, and the kid is up for it and they're motivated. But if not, then it can be a difficulty. So in our clinic, a public hospital setting, we've got about 1,500 young people with diabetes. And our approach basically is to have standardized education for everyone as a newly diagnosed. With insulin therapy, we always start on injections, and we do start either on twice a day or multiple daily injections. A lot of that comes down to the age of the child. We'll generally have a conversation with the families about the fact that both are available, but around practicality, we'll discuss what's going to work for them in terms of their practicalities of day-to-day life. In terms of pumps, we've probably just under 30% of our clinic use a pump. That's never from diagnosis, for practical issues mostly, but also we generally have requirements that they're quite a selected group, a requirement that they've shown that they can engage with the rigors of injected therapy regimens in terms of monitoring their blood sugars and being aware of carbohydrates, that sort of thing, so we don't want to set them up to fail, essentially, going on a pump. And then we have strict or tight glycemic targets, both in terms of HbA1c and blood sugar monitoring, and we ask families to self-adjust and give them advice and help and support in that regard. Prior to the beginning of April, we've had quite a low uptake of CGM, a little bit increased with the availability of the Libra, but overall that had been low, and I suspect that will probably increase across the board. So I guess you're going to go back and say, well, hang on a second, isn't that twice a day regimen? Isn't that the one in the diabetes control and complications trial that was bad, and that showed HbA1cs that were well above the other regimens, and why would you use that? And I think there is an important distinction. So in the DCCT, the conventional therapy, because they had no knowledge that hyperglycemia was pathophysiologically related, they had either 1 or 2 injections of insulin, 1 blood sugar a day. They were basically treating to try and avoid hyperglycemia or ketosis. It wasn't intensively driven. So the intensive therapy, on the other hand, was a step beyond what is available outside of a research setting, really. So 3+ injections of insulin or an insulin pump. And so intensive therapy often gets, using either MDI or an insulin pump often gets branded as intensive therapy, and BD often gets branded as non-intensive therapy. But I think most families who have kids who have diabetes who are on twice a day insulin will tell you that it's not a non-intensive regimen. It's still pretty intensive. 4 blood sugars a day, active adjustment of doses. These are things that we do in our twice a day insulin injectors, regardless of that they're not on MDI or a pump. And it's important to show that in the DCCT, 96% of the treatment group effect was explained by variations in HbA1c. So it's not just the regimen. So while there are, apparent or seemingly intuitive benefits of having a more physiological replacement of insulin, at the same time, less than 7% of the variation in risk for long-term complications related to that. So HbA1c is a much firmer or much more robust measure in terms of impact on outcomes. And so in terms of RCH, so based on the ADDN report, so the benchmarking across these 6 centres that were included in the September last year, 2016, and overall in Australia, about 40% of kids are using insulin pump, similar percentage using multiple daily injections, and just under 20% using twice a day, whereas at RCH, ours is different. So we have about a quarter of this cohort on pumps, just over around a third on MDI, and the majority of our patients are on BD. The majority of those are probably primary school age children. However, we definitely have a cohort of BD insulin users who are in adolescence, where for various reasons they haven't been able to keep the motivation for adhering to either using a pump if they've come off their pump, or just do not want to be using multiple daily injections, aren't able to give the 4 injections a day. And there's really very little point in nominally being on a regimen of 4 injections a day if you're missing out on 20 or 25% of your insulin as a routine thing. So we do use BD in that cohort as well. And our HbA1cs are fairly similar. So again, like the other studies that have shown this, our mean HbA1c was very similar to the overall mean HbA1c, as was the median. And you can see similarly, we're slightly higher figures, although well below where we would like to be in terms of percentage of kids achieving the HbA1c target under 7.5. About half of the kids are in that stuck range of 7.5 to 9%. And there are, again, about a fifth of kids who aren't achieving good control at all in terms of HbA1c measures, and who are struggling, and that's where things like, all of the additional goals in terms of optimizing their general well-being, but also mental health support, all of those things, they're going to school, those kind of things, they're important for everyone. But again, in that higher cohort who are struggling to get their sugars under control, it suggests that there are lots of things at play. This has been the case in lots of other studies. So these are observational studies. They're not selected cohorts and they're not controlled trials, but across the world, basically, there have been registry data that have shown no link between insulin regimen and HbA1c outcomes. There are also some data showing that pump therapy has lower HbA1c levels versus multiple daily injections, and some very big cohorts like the SWEET registry or the German and Austrian registry data. So again, there's no universal, I think the bottom line is there's no universal one way. I think there is nonetheless this rise in diabetes technology uses, and I think we just need to keep a sort of questioning approach always as to what the data is and what the benefits are. And this, I think, from the ADA, there's similar statements in all of the international guidelines, but basically no matter how sound the medical regimen, it can only be effective if the family or affected individuals are willing to implement it. And that's, I think, why we have this sort of multiple pathways to a common goal, because there's no one way. Any of the three pathways can get you to where you want to be. We've got kids achieving their HbA1c targets, achieving good blood sugar levels, pre-meals on all regimens, and we've got kids who struggle on all regimens. So there is no one way that suits everyone. I think, again, I guess this questioning thing, so it's interesting how things creep in, and so pump therapy and the use of analogues similarly are increasing, and I think will continue to increase. And I actually think that there's not going to be any more evidence, because I don't think randomized control trials are going to continue to happen. But interestingly, there was a debate at the ISPAD annual general meeting in 2014 around this fact: is new technology improving diabetes care? And when sort of the facts or data of the meta-analyses were mentioned on one side, the answer to that was that we should ignore Cochrane reviews and randomized control data when we know that they're wrong. And that was from a senior ISPAD council member. So that was from someone who's an academic researcher themselves. So I think it's just something that we need to keep in mind. From an RCH point of view, so Fergus, my colleague who has been involved in this VIDERA international comparison study, which is 21 centres around the world, and they have done a number of comparative data studies as well. And overall, one of the big things that they've shown is that agreement in targets, so where clinicians and kids can agree on a target for HbA1c or for blood sugar monitoring, or where families within themselves, so it doesn't matter whether it's the kid or the parent whose job it is, but as long as both the kid and the parent agree on whose job it is. If you have defined outcomes, defined targets, you can be flexible in your approach towards getting them, as long as people know where they're headed, basically. So where to from here? I guess from our point of view, there's always this overlying ethics of running a public health service in terms of equity and credibility. And the equity is a big issue in terms of, so pump therapy isn't universally available. And even if it was universally available, the cost of that comes from somewhere else in the public purse. And there's the sort of dilemma of the patient who's in the room with you, and you're having a chat, and they, are talking about some option for diabetes care versus everybody else who's in the waiting room versus everyone else who's down the corridor in the cystic fibrosis clinic versus the oncology clinic versus everything. And that's, something I think as clinicians we try not to think about very often. I suspect Jenny probably spends more of her time talking or thinking about that kind of thing. But at the end of the day, it is, there's a finite public purse, shall we say. So from a diabetes point of view, there's probably moderately expensive therapies relative to some of the other drug and device therapies, which have varying efficacy, which can be rolled out to a lot of patients. And we need to keep in mind the potential benefits and potential downsides of that. And really, I guess overall, in terms of any service, achieving the greatest good for the greatest number of people, and that ranges both from people using technologies to, on the left, the Insulin for Life program. So, in relative terms in Australia, we are so lucky relative to internationally, and all of this talks and things today are all in that setting. It's humbling in terms of the number of countries where there isn't insulin available. This, just to go back to your 10 cents, Phil, I thought you might like this. So this is, in terms, we talked earlier, so the difference in some MCTs or meta-analyses has been about 0.3%, some have shown no difference. This was a fairly simple study run in the States and published in Diabetes Care about 2 years ago, where it was a 12-week program of kids were enrolled. They were offered 10 cents for every blood sugar that they did, and they increased from just under 2 a day to just under 5 a day, 5 a day being a recommended number, and beyond 5 there isn't actually that much evidence for improved or additional improvement in HbA1c. But the HbA1c benefit of this was a lowering of about 0.9% to at an average cost of $120 a year. And it was maintained out to 12 months, which is interesting, even though that was rolled out over a 12-week period. And that's, I guess, 3 times the improvement at a 30th of the cost. Nonetheless, there is no doubt that technological advances continue to hold considerable promise. And I think in the next few years in particular, there's going to be possibly some game-changing things coming in terms of the interplay between, interplay between CGM and insulin pump therapy. At the moment, insulin pumps can respond to CGM insofar as they can turn off insulin if either you are low or the pump algorithm predicts that you're going to be low. But the next generation of pumps will be able to deliver insulin in response to the blood sugar, or not blood sugar, but tissue sugar data that it gets. And I think that's a game changer in terms of if you had diabetes, and one of the big limitations of pump therapy is that the insulin isn't delivered. The insulin that is required isn't delivered for whatever reason. The button isn't pushed or the settings aren't right or whatever. But if the interface of the user is taken out of it and the pump and the sensor are doing their own thing, well, then that could be very different. And the initial results are very encouraging, but I challenge you to keep your skepticism to the fore. Nonetheless, I do think these technologies may well be transformative, and that's possibly when the public purse will need to change for availability. But that's where the health economics comes into it. So, the potential savings down the track of, wide scale, not only down the track, but wide scale improvements in acute things, kids in the classroom, kids, playing sport, kids sleeping at night, families sleeping at night, and also, lower rates of cognitive impact, lower rates of kidney and eye disease over time. If that all adds up, then that's a big tick in the right direction. Until such time as that may be the case, I'll leave you with a quote from Richard Ashe from the middle of the last century. So if you're too lazy to think for yourselves, you'll fall an easy prey to the less thoughtful papers and publications, blindly accepting the myths and maximus. I'm not suggesting that that's entirely the case, but just being a bit glib. Thank you very much, and I will be happy to take questions.